Good afternoon and welcome to Facebook Live. This is Dr. Bill Bird, Chief Medical Officer at CGH Medical Center. Thank you for joining me today, Thursday, June 2nd, for Facebook Live. And today I'm going to give you the roadmap. So today the roadmap is Dr. Matthew Cutter is going to be my guest to talk about eyes and eye health and eye conditions. I think Dr. Cutter is very good at talking about eye-related matters. So looking forward to that. And then when we're done with Dr. Cutter, then I'll give a brief pandemic update. And then I have a few other little shout outs and those type of things to do at the end of our call too. So without further ado, let's kick this off. Let's get Dr. Cutter in here. Hi, Dr. Cutter.
How are we doing? Very good.
Good to see you. Look, I like
you too. Thank you.
For those of you who have had any eye checkups done, that background of Dr. Cutter's should be pretty familiar to you. Yeah. So, okay. So, Matt, are you ready to take on a few questions?
I am. Fire away. No problem.
Okay. All right. So, and for those of you who don't know, Dr. Cutter has been with either the Sterling Rock Falls Clinic or now CGH for, gosh, I'm guessing. I'm going to say 24 years.
26, 27, somewhere in there.
All right. Longer than I even thought. Yeah.
Yeah, it's been a while. So,
yeah.
But it's been wonderful. I mean, obviously, I'm happy to be here. It's my hometown. So being here is, just like being home.
Yep. That makes sense. So I asked that question just for our viewers to get a sense that Dr. Cutter has been doing this for a long time.
Yeah, I'm old. I get it.
No, I didn't say that, but doing this for a long time. And he knows what he's talking about. So start with some basic stuff here, Matt. Okay. First of all, just what is a cataract?
So cataract is anything that makes the lens in the eye less clear. So we have a physiological lens in our eye. That's what we use to focus with. Anything that makes that less clear. So over our lifetime, it gets yellow just because it does. And that's just from using the eye, from sunlight, from things we eat, environmental factors. The lens yellows over time. That's nuclear sclerosis. That's the normal aging type of cataract. Then there's other things that cause then the cataract to get, or the lens to get more dense. And those are just different types of cataract. But in general, anything that makes the lens less clear would be considered a cataract.
How would somebody know if they might be developing a cataract that needs attention, Matt?
And the most common things people come in and say, I can't, and whatever it is, I can't see well on the TV. I can't read my pill bottles. They notice that when they're driving, they can't read the signs as well. Those type of things. Or the other common one is glare. I get glare on headlights at night, or the headlights have an extra halo effect. Things like that are what people notice the most. Some of that could be other things like just that your glasses prescription have changed and we need to update that. But cataracts cause those type of symptoms.
Yeah. So is that the time when most people end up, you sending them to Dr. Hahn or like that for surgery?
We talk about removal when we can't fix it with other means. So basically it has to affect your daily life in such a way that you say, I can't, again, whatever that is, and you really need to be able to do that. We can't fix it with glasses or something else to make it better. And the cataract center, the cause, that's when we start talking about removing them.
Yeah, that makes sense. Hey, by the way, for those of you who are watching us, as always, if you have questions, please send them our way and we will get right to them and do our best to answer them. So next eye condition to talk about is glaucoma. What's glaucoma?
Okay. Glaucoma is a disease where the pressure in the eye is high enough it damages the optic nerve. So it takes both of those things, pressure, and then actually it just takes damage. It can be at any pressure, but it actually takes damage to the optic nerve. So the eye has, the cornea and the lens do not have blood vessels. So they bring nutrients through filtered blood that comes into the eye and then flows back out of the eye. That generates a pressure inside of the eye. Everybody's pressure is different, whatever your baseline pressure is. Sometimes that's high enough that it pushes on the optic nerve then and damages the optic nerve. So that's glaucoma. Pressure that's damaging the optic nerve.
Who needs to get checked for glaucoma? What's the typical recommendations on that?
Everybody needs to get checked. It's rarer in kids, but it can happen. And then it's more likely as time goes by, just because that pressure has been pushing on the eye longer. It's not because the eye is necessarily aging. It's just because it's had, more pressure on it over our lifetime. So it does become more common as time goes by. The biggest problem with glaucoma is there's no outward signs. If you come to see me in glaucoma and you have glaucoma and it's advanced, you might not know, and there's no way for you to know without getting a regular checkup. That's one of the biggest reasons we recommend annual checkups, is to look for things like glaucoma because they don't have outward signs.
How do you check for it?
Pressure is the number one thing. We look at the pressure, and there's really 3 risk factors for glaucoma, and we check all of them during a regular eye exam. The thickness of your corneas, the shape of your optic nerve, and then your pressures. So a regular eye exam, we look at those risks. If you have those risk factors, whether it's one or in combination, then we start thinking about then actually testing for glaucoma, where we measure the nerve fiber layer, part of the eye that gets damaged in glaucoma, and your side vision, again, the first part of the eye that gets damaged in glaucoma.
All right. I want to switch gears to just a question or two about diabetes. It's a big deal with your eyes. And can you kind of explain why that is, Matt?
Sure. Diabetes has a couple of effects. The number one reason we dilate then diabetics is because the blood vessels get damaged. We talk about diabetes being a sugar disease. People talk about their blood sugars where they are. It's really a vascular disease because it hurts the blood vessels. The body then taking that sugar, which is at an irregular concentration, it pushes it in and out of small vessels throughout our body. And because the eye is full of small vessels, it's an end organ, meaning vessels that get to the eye, turn around and go straight back then to the heart. They don't make any other path past the eye. So it's full of small capillaries. As that sugar gets pushed in and out of there, those vessels get weaker. As they get weaker, then they can leak blood. That leaked blood into the retina causes then damage to the retina. But also because the vessels are damaged and not flowing blood the way they should, the blood's not getting to where it should be. And then you actually get then damage through lack of blood in the retina. So that's where the damage from diabetes comes from in a diabetic person.
Yeah. And the idea being, obviously you want to control your diabetes and help prevent those blood sugar fluctuations.
Absolutely. The more stable your blood sugar is, less likely the body has to push that blood through in and out of those vessels.
Right.
And then exactly that, it's less likely to create problems. And even if we see problems early on, a lot of times if your blood sugar gets under better control, those will actually go away. We can reverse them in the earliest stages. Later stages, we cannot. That's why we want to catch it early on.
Yeah.
Yeah.
All right, good. And I want to talk about another common eye condition is macular degeneration. What exactly is that, Matt?
Okay. The macula is the area of best vision in the center of our retina. The retina is made up of a number of parts, but right in the center of it's called the macula. The macula then is a number of layers. The outer layers have blood vessels, and then there's pigment layers, and then the nerve layers, the part that we detect light from. Macular degeneration is where those layers get disrupted. They get broken down. As they get broken down, then it obviously affects the nerve layers on top of it. They don't function as well, and you lose vision in those spots, which is why macular degeneration at the end of this will actually damage your central vision, where you lose your central vision because those nerves are not functioning well.
Okay.
We think it's related. It's related to a number of things, but one of the things we know it's related to is ultraviolet light. So sunlight creates free radicals in the retina. Those free radicals then damage the retina. That's where the damage comes from. That's why sunlight protection is worthwhile for everybody, just because then it helps lessen that damage from ultraviolet light throughout your life. We also think then antioxidants, lutein and zeaxanthin in particular, which are carotenoids that are found in high concentrations in the retina, help prevent then or have a positive effect in macular degeneration because of the fact that they then take up those free radicals and hopefully help prevent damage.
Yeah. So we talked about this. Matt did a segment with our medical staff and asked some medical, kind of answered some clinical questions for our medical staff about eyes recently. One of the things you mentioned was that sunglasses don't necessarily protect you. Can you talk about that for a second?
Sure. Ultraviolet light, like I said, is the problem, the negative effect in macular degeneration. So with that, not all sunglasses block ultraviolet light. Ultraviolet light's clear. You don't see that. So blocking ultraviolet light, which your car window, a lot of car windows have some UV inhibition in them to help protect the inside of the car, but your car windows are not necessarily tinted. So a tinted lens doesn't always block ultraviolet light. You can get UV inhibitors in your regular clear glasses and not see the difference in tint. And the same thing, sunglasses that are tinted don't always guarantee that they block ultraviolet light. So you have to make sure your sunglasses or your regular glasses have a UV inhibitor. It usually will say something like 100% UV blocking, things like that, to make sure that it is blocking light. Some of them will say UV blocking, but if they don't say 100%, they might block only 20% or 30%, which is not enough then to add the protection that you want. So you're going to look for 100% UV blocking.
Okay. All right. I thought that was worth asking.
Yeah, if people make that mistake quite often, they'll get they say, oh, I wear sunglasses. Well, depends. If they have the good UV protection, then it's worth it. And we actually can measure that. We have a UV meter. We can measure that here if you have questions on that.
Nice. Very nice. Good. Okay. Another question. Any suggestion? Let's talk about glasses. Any suggestions from your experience, Matt, of what patients would benefit most from readers versus bifocals versus trifocals versus
Sure.
progressive glasses?
Yeah.
I'm sure you get that question all the time.
It's a very common question. And a lot of people say, does my prescription, do I need a trifocal or do I need the bifocal? And it's not based on your prescription. That's the thing that a lot of people, it's easy to get confused on that because you think you'll come in and I'll prescribe that and say, oh, now it's time for your trifocal or it's time for, and that's not doesn't work quite that way. Trifocal, bifocal, no line, readers, however we're going to correct that, it has more to do with how you function or what you need in your daily life. So if you need distance and near at the same time without having to take glasses on and off or switch from one pair to the other, then a bifocal is the choice because you get distance and near. Now, whether you use a no line or a line, again, depends on what you want as far as there's pluses and minuses to each, but none of them are like, well, this is the one you have to have. Same thing for trifocal. That just gives you 3 focusing powers. So you have distance, intermediate, and near. So let's say you need that. You need far away, a computer, and reading all at the same time. So a trifocal or a progressive, a no-line bifocal, which blends from distance to near. So that's a multifocal, more focal lengths than a trifocal. Then that would be a benefit because, again, it's more based on what you're going to use.
Yeah.
Some people don't like the bifocal because they don't want to have to tip their head to find the reading portion of it.
Right.
And with that, then we can use 2 separate pairs of glasses. If you have a distance prescription, then a distance pair and a near pair. And again, nothing wrong with that as long as you don't mind switching back and forth. So it's more about what the patient needs, what fits into their lifestyle, more than it is a prescription. I would say, oh boy, here's what you have to have.
How long would you say in general? Because I have to admit, I got a pair of progressive glasses from you, Matt. Mm-hmm. It's just it's challenging to kind of get kind of that just the right position at times. Sure. How long does someone really need to just give it the old college try?
Yeah, and that varies
before they get used to it, or just find out that it's just not going to work.
Yeah. It varies. It depends on the prescription itself, also. Because if you have very low prescription and you don't wear glasses at distance very often, or you've never really worn them much, it is much more difficult to get adapted to a bifocal because it's completely different than what you're used to. Now you're getting used to wearing glasses, getting used to a bifocal, all of that together. That is harder and definitely takes longer, especially if you don't need them all the time because you're really not wearing them all the time. You're taking them on and off still, so you're reinforcing what things have always looked like. So that takes longer. If you've always worn glasses, you've been in glasses all your life, and you're used to wearing glasses and so forth, then it's probably easier to adapt to that bifocal.
Yeah.
We tell people a week, 2 weeks at the minimum to kind of get used to them. If you're wearing them for a week and you're getting better, keep going a little bit. But after a few weeks, if you haven't adapted, we can always try to adjust them or make adjustments and see if we can do anything better, kind of with where they're positioned on the face, so forth. If that doesn't fix it, then we can always try a different type of bifocal, or again, go to 2 separate pair of distance and readers, or so forth.
Yeah. As you say that, it's kind of interesting too, because we really see with our brains, right? So our brains are used to a certain thing that the occipital part of our brain gets feedback from our eyes all the time, and when that changes, it takes a while for our brains to adapt.
And it's not just that, it's also we get then stimulus from our vestibular system. So when we move our head, obviously the world moves across our vision as our head moves or as our eye moves. Our brain then says, hey, did we move our muscles in our neck to move that? Right. The ears, the semicircular canals give us a signal that our head moved. So it decides whether the world moved or we move. So if you're in a car, the world moves by you, or we move, the world moves by you. It takes all those things together and adds them up to give you then that proprioception in the visual process. When we put a bifocal on you, it changes how that world moves in front of you. So all of a sudden your brain has to relearn, hey, when my head moves this much, the world moves that much. And those things definitely take time. And some people can't adapt to it. Truthfully, more people adapt to it. We do bifocals more than we do separate. And when I say bifocals, I mean a progressive or a line that's a generic term, bifocal. Yeah. We do more bifocals than we do reading only or separate pairs.
Sure. Speaking of folks who just glasses aren't a good fit, let's talk contacts for a moment. Sure. So, yeah, people I think pretty familiar with contacts, but any new advances in contacts that our viewers might be interested in hearing about?
Yeah, the biggest thing that we probably do more of that are kind of specialty lenses are bifocal contacts. I wish I could say we have them for every prescription, and I wish I could say they were so great that it would be like you didn't need glasses, to where you didn't have to worry about where the bifocal is.
Yeah.
But it doesn't quite work that way. The thing that most people don't realize is when you're looking at distance, it takes 1 power to see far away. So 20 foot and beyond is 1 power. Anything closer than that takes more power, more plus power to see. And the closer you are, the more that is. So it actually takes a different power to see your computer than it does to hold something up close and read it. So the problem then becomes is getting all those powers in there. With bifocal glasses, we have a distance part and a near part, and you adjust then what part you're looking through. Contact lenses don't work that way. We don't have then a distance part and a near part, because when you move, the contact moves with you. So to make those work, you can think of it like a bullseye pattern. So it's got a little distance, then a little near, and a little distance, and you're looking through both at the same time. So it gives both things in focus, or as good as it can be.
Yeah.
But I can't take a lens that was 100% distance and divide it up and make it as good far away as it was when it was 100%. So I tell people with bifocal contacts, we always give up the distance a little bit to gain that up close. So if you're willing to make that compromise, say, I don't mind giving up a little distance to get that up close vision, then you're a good candidate for bifocals. If you say, no, I want to see perfect far away and perfect up close, if I'm going to do this, I can't do that. So unfortunately, you're not the best candidate then because of that.
Yeah. Okay. That's fair. Okay. Retinal tears.
Sure.
What exactly is that? And how would you know if you had it?
Sure.
And what do you typically do for that?
So we talk about the retina with the macula. That's part of the retina. The retina is basically, think of it like the film of the camera. It covers the back of the eye, and that's where the photoreceptors are that we interpret then light from. Okay. That is loosely attached to the back of the eye, because the eye is hollow and round. It's actually got a part that's, pulling down and comes all the way around. And then over time, there's a gel in the back of the eye. That gel breaks down as it moves around. It can tug on the retina a little bit. That tugging on the retina then can cause a hole or a tear in the retina. That hole or tear in the retina, if fluid builds underneath there, like if you had water coming down onto wallpaper, it would maybe separate that away. That's what a retinal detachment is. The signs of that normally are, as the retina comes away, little pieces are floating in there, and you get more floaters. That's why floaters are of a concern for us. That's why we ask about floaters and are concerned about floaters, because if it's part of the retina, then we're concerned about that. Mm-hmm. Also, if the retina moves enough, you get flashing lights usually. Usually it's an arc of light or a flash associated with that retina moving. So that's why we talk about flashes and floaters. If you see those, we would look to see if the retina is intact. If the retina is okay, then that's just the gel moving around causing floaters, because that can also, there's particles floating in the gel that cast a shadow in the back of the eye. So some floaters, which we all have to some degree, are benign because they're just part of that gel and nothing more.
Yeah.
Yep.
Good. And I had a floater question, but you kind of answered that one. So let's talk about allergies now. We're still in the allergy season, I would consider it.
Yeah, this has been a pretty good allergy year so far.
Okay. Any tips for folks who have allergies, let's say spring allergies, and how those affect their eyes and what they can do to kind of help with that?
Sure. Our first line of defense on allergies now is over-the-counter allergy drops. Before, let's say 5 years ago, I can't remember the exact time these came out, but a lot of the over-the-counter allergy drops were fairly, it just didn't work very well. So we didn't use a lot of them. Everything was prescription only. But in the past number of years, a number of what were prescription allergy drops, they're mast cell stabilizers, have now become over the counter. So Patanol is the most recent one that just came out. Pataday actually is the formula that's over the counter. Zaditor and Alloway, and now Lasticapt, which were all prescription drops, are now over the counter.
Okay.
So we start with those. Those are the ones that we start with always. If you have allergies enough that they're bothering you, your sinuses, things like that, sometimes oral medications will help with the eyes. Other times they will not. Yeah. So then if not, then we start with the over-the-counters and then go from there.
Speaking of like things that were prescription that have gone over the counter, back in the day, some of these nasal steroid sprays
Yep.
were prescription, and now like your Flonas's and Rhinocords and all these kind of things, they're over the counter now. If you treat yourself for allergies that are affecting your eyes and your sinuses with a steroid nasal spray, because there's a communication between the eyes and sinuses in terms of that nasolacrimal duct, will a Flonase of the world, let's say, will it help your eyes?
It can, yes. So we do see that sometimes, again, whether it's orals or, again, nasal sprays like Flonase, patients will say, hey, I do that and it helps my eyes. They don't tend to help a lot. It's not as common just because there isn't the direct interaction, since there's no blood vessels in the cornea. The lid has quite a few, so that sometimes will carry some of it there. But a lot of times it takes something more than that, which is why there's a lot of allergy drops.
Yeah, good. Want to talk about kids for a minute?
Yep.
The time that we have left.
Sure.
Want to talk about lazy eye.
Strabismus
is the medical term for that.
Yep.
What is it, and when is it something that parents or grandparents need to bring it to the attention of someone like yourself?
So anytime you see a turn, so an eye turn in or out, so strabismus is an eye turn in or out, and that can be actually part-time, which we would call aphoria, or full-time, which we would call atropia. The terms themselves don't necessarily matter. It's just that you see an eye turn. We would look at that and decide whether it's part-time, full-time, and how much it's there, and whether that eye is being affected by that. If it's part-time and the eye is straight the vast majority of the time, even 50% or more, and the eye's developing normally, vision looks good, we would do nothing about it. It wouldn't have to be corrected. It's when it's starting to affect the eye, because if they're not pointing at the same object, they can't develop well together. The eyes develop, actually, when we're born, our visual system is not fully developed. It develops through our lifetime, up to the age 6 primarily, but some into our teen years, where that input is what develops that. So if one eye is not working as well or not pointing at the same object, it won't get the same input, and it will underdevelop. That's when it becomes a concern. So that's something we would have to measure. But parents or grandparents, if you see that turn, and it's everyone, they're tired and all of a sudden you see it and then it goes away, it's probably not something I would rush right over. I would bring it up at just regular eye exams. But if it's something that starts developing, you say, boy, that's there quite often, 50% of the time or 20 or 30% of the time, I would definitely have that looked at.
Yeah, good. Final medical question. I want to talk about ptosis, or kind of a droopy eyelid look.
Yep.
Tell us about that, and when do patients need to seek medical care for that condition?
Sure. And we can see that in kids every once in a while. And in kids, it's almost kind of the same criterion. We look for when it's blocking the vision enough to keep that eye from developing well. So all of a sudden it's blocking about half the pupil, then the eye will not develop well. That's a concern. So that would be repaired in a child. Because the children are still growing, sometimes they can have a ptosis when they're young that will get a little bit better as they get older, because they physically get bigger and it doesn't block as much. So if it's not blocking half, we would leave it.
Sure.
In an adult, it is just usually time going by and gravity pulling down on everything, and it starts blocking vision. It can be taken care of at any point in time cosmetically. So if you come in and say, I don't like the way this looks, or hey, I feel like if I do this, I see better, a surgeon could take care of that pretty much at any point in time, but it would not be a covered expense with your insurance, because that would be considered cosmetic when it's just early on. When it gets to about half your pupil, it starts affecting your vision enough that it's affecting your daily life, then your insurance companies would then more likely cover it. There's a couple of tests we do. We do a visual field with your eyelids taped and then untaped to see how much it improves the vision. If we can show enough improvement, then insurance companies likely to cover it. Or if when untaped, it covers enough of your vision, then they're more likely to cover it.
Great. Okay, final question.
Sure.
So last time you were on, I asked you who your favorite employee was. That was a couple of years ago.
Sure.
I'm just giving you the opportunity. Is your favorite employee still the same one, or I'll give you this opportunity now to really just bury yourself if you want to.
Yeah, thanks. It is actually still, because I have the exact same staff since before. And I think I'm very lucky in that. I've had the people that work with me every day. They've been here now for a long time. And so my technicians, and I'm going to go by order of how long they've been here, not how old they are, because I'll get me in trouble if I talk about how old they are.
Sure.
So, but Mary, Stephanie, and Nellie are my technicians that work with me every day, and I couldn't do this without them. There's no way. my optical, Lisa and Kara, both have been there a long time. Just opticians that are very good at what they do. Good enough that there are new materials that come out that they know about before I do, by far, because they handle that so well. And then Amy and Mary in the reception, again, keep my schedule doing very well. I'm blessed to have the staff that I have. I really am. And I know that sounds, people say that, but I really mean that.
Yeah. Well, I'm not around your staff as much as you are, but I can vouch for your comments that it's a really good crew.
Yeah,
really good
I'm
group.
lucky.
Yeah. And you know what? We're lucky to have you too, Dr. Cutter. So I want to thank you. And it's always great talking with you, whether we're on the camera or off of it. And thank you for your years of service and the great work that you do.
My pleasure. It's a treat to be here in Sterling. Like I said, it's where I grew up. It's where my family's from. I'm happy to be home.
Yeah. Thanks for joining me, and we'll have you on again.
Yeah, no problem. Anytime.
All right.
Very good.
All right. Bye.
Thanks.
Okay. So I wanted to transition now to just a brief pandemic update. And Matt has a few graphs to show you. And what I wanted to just give you a sense of, obviously we're in a little bit of a mini surge right now. So this is March 25th. And as I was looking through the weekly updates that I get, this was the lowest number of 7-day case rate that I saw back in late March. Low, and the percent positivity was pretty low then too. And if we'll keep going forward, now we'll jump forward, I think, to May 6th. You can see the number of cases on the top left there. Keep going, Matt. May 13th, 246. May 20th, 342. And then this most recent one was 230. So I'm hopeful that we've had a bit of a mini surge and that we're kind of making our way down in terms of the numbers of cases. And there's just kind of a graph, kind of a visual graph form of it, just to show that kind of look. Now, what fortunately is different about this particular little surge that we're having is some combination of the variant not being as mean and nasty, and or perhaps some built-in people that have been vaccinated and or have had previous infections. We're not seeing as many people get really sick and have to be in the hospital, although some do. But it's definitely in that regard a much kinder and gentler strain of this particular variant of the Omicron variant, which is good. And we'll see how this all plays out. All of us have been at this long enough to know that we don't know exactly what's going to happen next, but it's pretty likely other variants will develop. And the question just will become, how infectious are they and how sick do they get people? And time will tell. For now, I would just throw in for, once again, live your life, get fully vaccinated if you haven't taken the opportunity to do so. And if you're immunocompromised, you're the one group of folks that I'm talking to today, and those who see this later at some point in time. If you're truly immunocompromised, particularly if you're in an enclosed indoor space with a lot of people around, I would really consider still wearing an N95 or a N95 mask in those kind of situations, at least until our case count here in our particular area comes down some more. So just my thoughts on the situation at the moment. Okay, so I wanted to mention a couple other things. First of all, actually, we're having a blood drive at the hospital today, and my understanding is, thanks, Matt, there are still some open slots, last I heard. So if you're willing to give blood, sure, appreciate it. And there's the number to contact to look into that, or it looks like a website there too. Next thing I wanted to do is give a shout out to our employee of the month for the month of June, Greg Gillette. And Greg works in our IT department. I've known Greg for quite a while now. He does really good work. He's always pleasant to talk to when I run into him in the hallway. And my very best to Greg, and congratulations to Greg on this achievement. All right, and then the final thing I want to do. I guess I wanted two final things. First of all, I want to let you know that our next Facebook Live is going to be June 23rd. And it's going to be one of our physicians that always does a nice job when she's on here. And that is Dr. Young Song, our urologist here at CGH. And Dr. Song is going to be taking on the topic of sexual health. So we're going to be talking all things related to sexual health, both male and female, on June 23rd. So please tune in, and we'll look forward to hearing what Dr. Song has to say on that topic. So the final thing I want to say is, to those of you who are watching, thank you. Thanks for taking the time to watch us. Thank you for making this part of your, thanks, Marianne. Appreciate that. So thank you for all of you who have taken the time to watch this throughout the last 2 years or more, and are part of this ongoing conversation. And also just, we're trying to educate and inform, and thank you for taking the time to be educated and informed, and feel free to share this with other people so they can get the same information. Until next time, have a great, 2.5 or 3 weeks. Bye.